Hello everyone, this is a video about why a given mold treatment might not have worked, and then just some thoughts about treating mold in general. Just before jumping into the video, if you wouldn't mind taking a quick second to please like, share, subscribe, and or post a quick comment on the video, I'd really appreciate it. So thanks in advance for taking a second to do that. And as per usual, nothing I'm saying in the video should be construed as medical advice. This is for informational purposes only. If you need medical advice, please talk to your healthcare provider to get that advice. So the question today goes something like this. I have mold toxicity issues and had LDI, which is low-dose immunotherapy treatments, very different than low-dose naltrexone or LDN. Sometimes the terms are confused, but very different. So I had LDI treatments twice a while back, and literally noticed no effect at all. I always wondered why. So it's not an allergy to mold, it's potentially a lack of being able to metabolize and excrete the toxins, question mark. Do I have that right, question mark. So there's a little bit more to the question here, but just to stop there. So the comment was posted on another video that I posted a little while ago called low-dose immunotherapy for mold illness. And so I basically, in that video, went into the differentiation between a person being mold toxic, like i.e. the mycotoxins that are being produced by the mold are causing a toxic effect in their body, creating a lot of inflammation, leading to something that's oftentimes called the chronic inflammatory response syndrome. And so that's in differentiation to a mold allergy, which would be where a person was actually having allergy symptoms to mold, or potentially in some cases I'm having an allergic response where the presence of the mold is creating a lot of local inflammation kind of outside of an allergic reaction, and that could cause, really severe symptoms that might look exactly the same, potentially in rare cases, to mold toxicity. But when a patient in my practice anyways, goes on mold LDI and doesn't see any clinical improvement, then that's an indication that they very likely probably don't have a mold allergy. They might still, the therapy doesn't work for everybody's mold allergies, but they probably don't have a mold allergy, and that if there's a mold issue, it's very likely not a hypersensitivity to mold, but rather it's actually mold toxicity. So the person asking the question does seem to have that right, to my understanding at least. So it goes on to say, at least in the event okay, just mentions the thinking about maybe getting their genes tested. I appreciate the answer to this. May vary massively patient to patient, but I'd be interested to hear what your go-to basic approach to dealing with mold toxicity is, to see if I missed anything major since I'm reevaluating my case and considering what help to look for at present. So I have posted about mold toxicity protocols in other videos, but it's been a while and always happy to talk about it again, keeping it fresh. So when it comes to treating mold toxicity with my patients, I take a three-part approach. Now, not everybody needs all three of those parts, but I at the very least talk about a three-part approach. Sometimes we'll just start with one or maybe two parts, but in some cases then we have to bring in the second or third part. But generally speaking, when it comes to treating mold, the main goals, outside of getting away from the mold, the source of mold. So if a person has, toxic mold growing in their home, then hopefully that's something that can be remediated. If it can't be remediated, then perhaps the person can move to a different place, if it's say like an apartment rental or something like that. In some cases, folks can't move away from the moldy environment, or like in the near future, so it doesn't mean we can't still pursue treatment and try to damage control as much as we can, but generally we want to minimize the ongoing exposure, if not completely eliminate ongoing exposure to mold in the environment. And so once that has been tackled, or might be a work in progress, but in addition to that, in my practice, what I recommend for my patients is making sure that we're using something to fumigate the sinuses. So if mold has colonized the sinuses, then it's important to kill off that mold. We'll generally start with an essential oil-based nasal spray. Usually it's frankincense nasal spray. Sometimes we'll use silver-based nasal spray, and then in some patients, not all patients, but some patients, we then need to move on to a biofilm disrupting nasal spray, usually containing something called ETA, although silver itself has strong biofilm disrupting properties to it, but we'll work with some type of a nasal spray regimen. Another thing that's important for a comprehensive mold treatment is to make sure that the phase 1 and phase 2 and phase 2.5 pathways in detox pathways in the liver are functioning optimally. So certain B vitamins, certain minerals, generally a really good potency multi-nutrient, so a multivitamin, multi-mineral with methylated B vitamins in there. That's going to cover most of the bases needed for phase 1 and phase 2 detox pathways. Although glutathione, which is really important for phase 2 detoxification, it's important for clearing out a lot of mycotoxins. That's something that I'll recommend as a separate supplement because you're just not going to get that in a multi. So taking a liposomal oral glutathione supplement is something that I also recommend for my patients. And then the phase 2.5 pathway, sometimes we don't really need to do anything to directly support that. Phase 2.5 is this term that was kind of developed several years ago. I don't really know who came up with it, but basically it's referring to the transition of processed toxins from the liver into the intestinal tract, where the majority of them are then flushed out of the body through the bowels. So that transition requires adequate stimulation of bile flow and adequate availability of nutrients to actually make the bile in the first place. So if a person is low in phospholipids like phosphatidylcholine, that can be a problem. If their livers are just not being stimulated to make enough bile, then sometimes working with things called cholagogue herbs like greater celandine, for example, or milk thistle or dandelion root could be an option. Or sometimes taking digestive bitter herbs, sometimes known as Swedish bitters, or there's a company here in Canada called St. Francis Herb Farm that make a product called Canadian bitters, probably other bitter formulas out there. Herbs like gentian would be one of the most common bitter herbs, and it is indeed very, very bitter. So things to help stimulate that release of bile from the liver into the intestinal tract. And then phase 3 detoxification is making sure that we have adequate bowel elimination rather, so like regular bowel movements. That's very, very important, and regular urination, and if possible, regular sweating are great ways to help flush things out of the body as well. But as part of that phase 3 elimination through the bowels, in many cases, not all cases, but in many cases, taking an appropriate intestinal binding agent is important. So that might be a pharmaceutical medication like cholestyramine or Welchol, or it may be a non-pharmaceutical medication or supplement like charcoal or bentonite clay or modified citrus pectin or humic acid or fulvic acid or chlorella. Some folks will use Saccharomyces boulardii as a binder as well. So there are different binding options, and kind of their efficacy can vary from case to case. But having all of those things in place, so the sinus fumigation, the phase 1, phase 2, phase 2.5, phase 3 detoxification pathway support, those are really the main, that comprises a comprehensive approach to killing off mold and flushing out mycotoxins in the body. There are other things that are sometimes required, like supporting mitochondria along the way, treating concomitant infections with things like Lyme disease or Epstein-Barr virus, or getting rid of heavy metals, or doing additional work to support methylation pathways, or stabilizing mast cells with mast cell activation syndrome. There can be lots of other moving parts for really complex cases, but what I just described is, to my understanding, what a comprehensive, robust, specific anti-mold protocol would look like. So thank you for the questions. I hope that this information was helpful. If anybody has any questions or comments on this topic, or comments or questions about anything else, please feel free to post in the comment section below, and I will do my best to answer any questions as soon as I can.